This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
For those of you who don't know me, I'm Rachel Park. I'm a Nurse Research Fellow in the Cardiothoracic and Vascular ICU here at Auckland. I'm the current Secretary of the CTG and the Chair of the Intensive Care Research Coordinators Group. So the next presenter is Glenn Eastwood. He's Research Manager, ICU Research Manager at the Austin Hospital in Melbourne. He's also Adjunct Associate Professor at Deakin. And Glenn's got quite a large program of research he's undertaking into both oxygen and carbon dioxide control.
Thank you. Good afternoon. I'm delighted to be here, and I'm actually more delighted to be able to represent an extraordinary team of investigators, of which I get the delight to present the findings of our trial here today. And the trial is the Therapeutic Hypercapnia After Cardiac Arrest trial, being a pilot feasibility safety multi-centre randomised trial. Teamwork is what we're all about. The community, as Craig has demonstrated, has grown over time, and as a team it's how we're best to go forward. Cardiac arrest is a dramatic event, and it's a sudden event, and it actually carries a high morbidity and mortality. The figure below shows between 2003 and 2012 the mortality of patients admitted to the hospital following a cardiac arrest, and be it ICU discharge or hospital discharge, the discharge alive status of patients has largely remained unchanged. We did have the idea that therapeutic hypothermia, that was really promoted and well applied since 2004, was going to help with the outcomes of patients. Sadly, this isn't the case yet. What we do know about cardiac arrest is that post the event, the brain is exposed to hypoxic brain injury, and this hypoxic brain injury exerts profound effects on the long-term outcome of the neurological outcome of survivors. Recently in the journal Intensive Care Medicine, investigators from Europe tried to tease out why people were dying following a cardiac arrest, and for patients admitted to the intensive care unit, they wanted to understand the relative contribution of hemodynamic shock or neurological injury. And as we can see here, neurological injury, the black of the bars presented, presents later but has a profound effect on the reason why patients are dying. In the early period of time it's hemodynamic, but really the prolonged patient that you're putting most effort into unfortunately seems to be dying from a cerebral or a neurological event. There is evidence to understand why this might be the case, and in particular the brain is still under attack following cardiac arrest. You may have restored circulation, but the brain is not a happy place. It is hypoperfused. There is a growing body of work in animals to show that yes, at the time of the event there is no flow, immediately after there is severe hypoperfusion, and this hypoperfusion continues during the first few days and prolonged into the post-resuscitation period. Existing studies have also identified in man that hypoperfusion of the brain is there, it exists. We can see from positron emission tomography that the brain is still hypoperfused. The graphs here show cerebral oxygen extraction, cerebral blood flow, but what I'd like to show to you is that blue is bad. You would really prefer to be more red and yellow, so it's still a very damaged brain. Again, using transcranial Doppler, with being above the red line mainly being normal, patients are continued to have hyperperfusion or lower blood flow to the brain. Again, when we look at jugular bulb oxygen saturation, the results are similar. The brain is not a happy place. And again, in more modern times, when we look at cerebral oxygen values by near-infrared spectroscopy, those that have lower cerebral oxygen values are more likely associated with dying than those with higher cerebral oxygen values. So I just mentioned oxygen, but really this talk and this study is about carbon dioxide and how we may best be managing it for our post-cardiac arrest patients. Arterial carbon dioxide is a major determinant of cerebral blood flow. Mild hypercapnia in itself is known to increase cerebral perfusion, as well as having anticonvulsant, anti-inflammatory and some antioxidant properties. So indeed, arterial carbon dioxide may in itself be a modifiable component of patient care that we could deliver to improve patient outcomes. These are the normal classifications of hypo, normo, and hypercapnia that are used in clinical practice, and it's what we apply to our studies. What do we know about our Australian context and what's happening to our patients admitted to the intensive care following cardiac arrest? This figure here is a study that we published in 2013 in the journal Resuscitation, where a number of colleagues and I looked at the Australian patient database, and using the worst guess on the admission to intensive care in the first 24 hours, we tried to understand the relationship with outcome based on the worst PaCO2. The figure at the top shows that, based on this worst PaCO2, that most patients, 40% of patients are normocapnic, 40% are hypercapnic, and 20% were hypocapnic. We also did some further investigation to try to understand where the derangement in CO2 occurs, and the vast majority of the derangement occurs early and then is corrected, and that is understandable that the patient comes to your unit in a deranged state, you intervene therapies to bring high numbers down and low numbers up, so that's what we can see here. When we looked at this 16,500 patient data set and we corrected and adjusted for outcomes, what we find was that patients in the hypercapnic group compared to patients in the hypocapnic group had a greater likelihood of discharge home if they survived. We are not alone in investigating the impact of arterial oxygen and arterial carbon dioxide in patients post-cardiac arrest. This is a study even more recently published by a group in Finland who looked at the 12-month neurological outcome of survivors post-cardiac arrest. The tall skyscraper in the back is actually carbon dioxide levels, and this is to show that patients who had the highest carbon dioxide levels during their ICU also had the greatest neurological improvement or recovery post-cardiac arrest. So this has led us to conduct and perform the carbon control after cardiac arrest trial and the study I'm presenting today. The aim of our trial, it's a little bit long, but it is to assess the feasibility, the safety, biological effect of 24 hours of therapeutic hypercapnia in patients admitted to the intensive care unit after cardiac arrest. For the purposes of the study, we classified normocapnia as being within the normal range, an arterial carbon dioxide value of 35 to 45, and we asked clinicians to target 50 to 55 if patients were allocated to the mild hypercapnic range. The study in itself has been published previously, the methods, and it's a prospective pilot multi-center randomized control trial, all of the details of which are here. But to give you some better concept about the patient experience and flow through the trial, this figure here shows that the patient has the cardiac arrest pre-ICU, which is the X. They have some pre-hospital care. They come to the intensive care unit and were assessed for eligibility and enrolled. The two donuts represent the time where either the patient was allocated to normocapnia or mild hypercapnia, after which the first 24 hours the clinician could decide to target whichever PaCO2 value they wished. We had a number of outcome measures being biological, which we assessed at baseline, 24, 48 and 72 hours, plus we followed patients through to ICU and hospital discharge, and importantly we looked at their functional outcome at 6 months. That being said, the primary outcome for our trial was the difference from baseline in two biomarkers, these being neuron-specific enolase and S100B protein. Both biomarkers are used to indicate neurological harm after cardiac arrest, and we wanted to assess these values at 24, 48 and 72 hours. And we had a series of secondary outcomes, these being feasibility, the ability to recruit patients, safety, concerns over raised intracranial pressure, in-hospital mortality, discharge home for survivors, and yes, importantly, the GOSE, the functional outcome assessment performed at 6 months for those who survived. I'd just like to quickly go over both the biomarkers because it's a concept that I need you to understand, and it's being a primary outcome, it's important that we all know what we're looking for. So neuron-specific enolase is a cytoplasmic glycolytic enzyme, and it's predominantly present in the neuron of the cells in the brain. After cardiac arrest, it is released slowly and peaks over a few days, 24 to 48 hours. And lower levels are actually associated with favourable outcomes. So although the trend of the biomarker values is to go up, in this instance you still want to be in the lower range. Again, S100B, a different biomarker. It's a calcium binding protein marker, and it's present in the glial cells and to a lesser degree in the myocardium and adipose cells. It helps to regulate neuron function, so it's located somewhere differently. Importantly, the release of S100B occurs quickly, and your values are high initially and then trend down over time. But like NSE, you again wish to be lower in this value over time, because that has been shown to indicate favourable outcomes. It's without doubt, I would like to acknowledge the funding support that I've had from multiple institutions, being both in Australia and in New Zealand, so it's definitely ever well appreciated that. And although I do not have any conflicts of interest, I'm interested in a conflict, so go the Wallabies. And it's a registered trial, so see how we go. It's now my delight to be able to present the results. This is our consort diagram. So over the trial we have had many research coordinators and clinical staff assess 187 patients for eligibility. Following exclusion, we were left with 86 patients who were assessed and enrolled. Of these, we had a nice distribution, 41 in the normocapnic targeted group and 45 in the mild hypercapnic group. We had 3 patients withdraw consent, it's their right, but it left us with a nice number. We had 83 patients overall in the study that we analysed. Our recruitment rate, it was a small 4-centre pilot study. Initially we were a single centre, battling away in Melbourne there, and then the yellow star shows that when you have friends, your recruitment goes up. And this study took 1 week under 2 years to complete, so it's very, very pleasing indeed, so thank you for everyone. I know Paul Young said it doesn't like table 1s, but I've got a table 1 for you to squint at. But also, I agree that they're not always beneficial, so I've helped us all out by highlighting some of the important features to demonstrate that the groups were similar at baseline. These being the age, also the cardiac arrest characteristics of time to return of spontaneous circulation, and also the proportion of patients that had VF-VT arrest were similar. And there was also a similar group with in-hospital cardiac arrest. This is looking, this table here looks at the ICU processes of care. So how were these patients managed during the ICU, and was it similar? Yes, it was similar. The patients in themselves, both groups had a similar number of arterial blood gases performed. Both had a similar proportion of cooling, be it therapeutic hypothermia or targeted temperature management or strict normothermia, and that the duration of intensive care mechanical ventilation time was similar between the groups, and also importantly the distribution of patients with full biomarker analysis was similar between the groups. What I failed to mention was that we were looking at a cohort of patients with 50 patients with full 4 time point biomarkers, and I'll present that data in a moment. But at the moment this is for our whole group. When you're trying to achieve separation, it's really nice when you get a graph like this that shows that at the start the groups overlap, and that when you ask clinicians to target and can you target different CO2 levels, they did it. They were able to separate and maintain some separation over the course of 24 hours. This was very pleasing. Patients in normocapnic group went towards normocapnia, and patients targeted towards mild hypercapnia were there. They were lifted up towards mild hypercapnia. We mentioned quite a lot of blood gases that we are assessed. When you take blood gases, we had the ability to look at 842, and there was quite a nice spread between the 2 arms of the study. So 404 gases were in the normocapnic group, and we assessed 438 in the mild hypercapnic group. And here's the distribution of gases as a totality across the 24 hours, just to show that gases were being taken similarly for all patients across the first 24 hours. Looking further at the arterial blood gases, what I'm trying to show here is the distribution of the gases when we classify them into the hypercapnic states. And when we look at the normocapnic group, it's really pleasing to have seen that the patients had, on the majority of time, were in normocapnic range. This, in comparison to the mild hypercapnic group, shows that patients who were allocated to mild hypercapnia were in the mild hypercapnic range or above for the majority of time, but rarely were they in the normocapnic group. This also plays out when we bring our lens back and look at the patients. and we use the mean PaCO2 over the first 24 hours, and what we again see is that patients who are in the normocapnic group spent the majority of their time in the normocapnic range, and when patients were allocated to mild hypercapnia, they too spent the majority of their time in the mild hypercapnic range. For those that are interested into what may or may not have happened with arterial oxygen, there is actually no difference statistically in the outcomes for patients of normoxia or hyperoxemia following in this 24-hour period. The study itself never asked or dictated anything to do with oxygen management. It was purely asked clinicians to target arterial carbon dioxide levels. Adverse events, we don't like them, we don't wish them on our patients. It was a concern of ours when we were asking clinicians to target levels, would or did there occur adverse events. There were a few, but cardiac arrhythmias were similar between the two groups, as was the initiation of CRRT. And for those that are possibly related to mild hypercapnia, we had no report of any episode of cerebral edema, we had no episode of hemodynamic instability, we had no report of pupillary dilation, and no report of seizures that were attributable to any of the patients allocated to the mild hypercapnic arm. The outcomes are clearly important, and there is a series of secondary outcomes, these being intensive care, discharge, hospital discharge, and discharge home between the groups. For the intensive care and hospital stay, there was no difference statistically, but a trend towards a shorter period of time in ICU for the mild hypercapnic group, but then extended by the time the mild hypercapnic patients got to hospital. ICU mortality was similar statistically between the groups, but in-hospital mortality showed a lower proportion for those allocated to mild hypercapnia. And again, when we look at hospital survivors who were discharged to home, the trend was in favour of those allocated to mild hypercapnia, despite not reaching statistical significance. But maybe importantly for ourselves and for our patients and their loved ones is the 6-month functional assessment outcome. Overall, we can see that when we base the GOSE on favourable and unfavourable, that the patients in the mild hypercapnic group had a greater proportion of a favourable outcome as opposed to those in the normocapnic group, again suggesting some benefit. It's not statistically significant, and the graph just helps us to understand where patients were on their functional outcome, and this is the overall GOSE for patients in the group. Obviously the big bar on the left is those that had died by 6 months, and the one on the far right is they have a very good functional outcome. That's interesting overall, but what really begins to stand out clearly again is that when we divide the GOSE per group, we see that those allocated to normocapnia did worse, and there is a greater proportion of patients with a greater functional outcome or functional recovery in the hypercapnic group. I did mention biomarkers, and these are important, and these were done on a series of patients, the 50 patients that we were able to obtain the 4 time point biomarker analysis of, and we just wish to stress that the reasons why we didn't get 4 on everyone is good and is not so good. Patients do get well enough and do discharge early, and some patients die in the intensive care unit early. But we saw an even distribution of patients in each of those categories for each of the groups, so we don't feel that there is any great bias by excluding these patients. For neuron-specific enolase, if we remember, this is the biomarker that initially starts low and goes up, and again you wish to be in the lower group if you have a trend towards favourable outcome, and indeed that is what we saw. We see here that patients in the mild hypercapnic group had attenuation of the neuron-specific enolase release into the blood, and that's what we see when we break the group. S100B was the neurological injury biomarker that was released early and trends down, and this is the figure for the overall group. Although this didn't reach statistical significance between the groups, once again the mild hypercapnic group was lower in the release and levels of S100B, so again suggesting some attenuation of S100B injury. So I've spoken quite a lot and gone through quite a lot, so I have 4 key findings to bring to your attention now, and that is that being a pilot feasibility study, it was really encouraging, and it really gives us some faith into the future to understand and know that arterial carbon dioxide manipulation is, and it was, possible for ventilated cardiac arrest patients admitted to the intensive care unit. So much so that we feel it is feasible to target particular arterial carbon dioxide ranges and to indeed achieve separation in those ranges if desired. Moreover, the neurological injury biomarkers did change over time. They were not worse for those in the mild hypercapnic group, and possibly a little bit better for NSE and for patients treated with mild hypercapnia. And importantly, we saw a similar proportion of patients with favourable outcome at 6 months for those overall, but maybe an idea of a trend towards a favourable outcome in the hypercapnic group. The large study that we did that I presented earlier in the piece is probably one of the ways we can compare this to, being that there's still not a lot out there, but what I can sort of demonstrate is for the patients allocated to mild hypercapnia in the feasibility trial, they actually had a lower proportion of patients with hospital mortality compared to the large data set, and again this was similar with a lower proportion of death or failure to be discharged home in those compared to normocapnia. And again, we saw an increase in actually the proportion of patients with a favourable outcome being discharged home if you survived. So what does this mean in clinical practice? Well, it actually supports the view that mild hypercapnia can be reliably delivered to cardiac arrest patients in the intensive care unit, that we saw achievable and acceptable recruitment rates across our 4 hospitals, and that yes, it is possible to achieve separation between groups. The study is a study and it's not in itself unflawed. It's limited by our study being non-blinded, but it's really difficult when you're targeting a range to blind it. Our exclusion criteria might have introduced some element of bias. We have exclusion criteria that wouldn't have enrolled just anyone that came to the intensive care unit, so if they were coming up from the emergency department and were being palliated or had severe acidemia, we weren't putting them in straight away, so you're almost backing a winner, so you're excluding those that are high likelihood of dying. And we didn't have the actual statistical power at this stage to detect a meaningful outcome at 6 months. That all said, our findings do support further evaluation of targeted therapeutic mild hypercapnia during mechanical ventilation on patient-centred outcomes, in particularly functional outcomes, for those patients admitted to the intensive care unit following cardiac arrest. Thank you very much.
Thanks, Glenn. Great presentation of a well-designed study that's been undertaken, so thank you for presenting it. We do have plenty of time for questions. Before we get started, one of the things that jumped out, 842 blood gases in 84 patients in 24 hours, that's quite a few.
Yeah, you may be overgassing our patients a little bit. I could imagine a little bit more occurring early in the hypercapnic group if you're concerned. Pleasing to see we saw a balance, but the findings of the number of gases is actually replicated in a couple of other studies we see, that the Australian practice is to do about 8 gases or so in that first 24 hours. It is different than overseas practice. I've noticed a cardiac arrest paper from investigators in the United States that do an average of 2 or 3. But I would suggest that maybe we are just higher vigilance for our patients and trying to correct abnormalities a little bit sooner, or be aware of them a little bit sooner.
All nurses want something to do.
Hi, it's Maureen Kilmister from Lismore. I was just interested in your normocapnic group seemed to have a slightly higher percentage of patients who actually were hypocapnic at some stage, and I just wonder whether that might contribute to the difference, and what would be your comment on that? Yeah,
very true. Before patients got into the trial, it's quite likely that any derangement in arterial blood gas that was occurring, it was included. So we assessed them. Sometimes it's really difficult to control arterial blood gases on patients. There's quite a spread. Even in some of the patients, when we look at the gases that were allocated to mild hypercapnia, then we never got there. You'll never be able to get some patients there. So I think what we saw was a realistic representation that clinical management of patients, and gee, can we do it, is a bit messy. But pleasingly, when we looked at the mean CO2, the vast majority of time people were actually in the right swimming lane, if you want to put an analogy with it.
John Green from Northern in Melbourne. Glenn, it seems that cerebral edema is not such a harmful influence on the outcome of people in this situation. Have you got any speculation as to what were the factors that led to the better outcomes associated with the hypercapnia?
My hunch is that it is all related to raising cerebral oxygen values, and we can use arterial carbon dioxide as the driver for that. We've done some recent preliminary work looking at evaluating normocapnia, mild hypercapnia, and normocapnia on cerebral oxygen values, and for those patients that we are assessing that and comparing the two levels, if you raise the CO2 you have an increase in cerebral oxygen value despite not changing the oxygen. So I think it all goes back to the fundamental studies of a hypoperfused, at-risk, very upset brain that we are underappreciating once we get hemodynamic stability. So I think although you'll get increased blood flow and there is yet the theoretical risk of increased intracranial pressure, I think we must balance it with getting back to at least a cerebral normoxia or maybe cerebral superoxia, I would say.
It was a little bit hard to see the process of care slide from where I was sitting. One of the things we found, in order to achieve hypercapnia, it seemed that there was sort of more use of neuromuscular blockers. Did you record that? Did you analyse it?
Well, we did, and we used we did write it between the groups. I'll have to go back to the figure to have a look, but I'm hesitant to change it. You can't. You upset the sequence. We can't go back. It could be a confounder. There could be the need to do more neuromuscular blockade in patients. If you're aggressively managing it, maybe we would protocolise it into the future. But being an adjunct to the current therapy, in which we only ask them to target it and let all other management occur, it's hard to know the clinical decisions behind what they were doing. It may be best to do that, but I don't know. Yeah, I don't know.
Glenn, a fantastic study, and a double-barrel question. What are you going to do next? And can we quote you when we're having a fight with neurosurgeons next time about a CO2 that's maybe 44.9 and they say terribly toxic? Can we quote you on that one?
Please quote away. I'm not as fearful of neurosurgeons because I can duck and weave, but it's. I think the fear behind it just isn't evidence-based per se, and we need to do more of these monitoring to show them to understand it's going to be safe. I remember I presented some work to neurologists at the Austin saying I was going to 50 to 55, and they almost fell off their chairs as well. They go, gee, you go up by 1 millimetre of mercury and all this happens in the brain. I'm like, yeah, but we go up by 15 and we sort of don't sweat it and we come. They're like, wow. So it's a competing perspective on the brain. That the brain is their organ, they're protective of it, and they're trying to do their best. We've got a whole body system to work at, so we can try our best. The where to from here, I'll get back to the second question. Look, I'm delighted that we're planning to do a sort of definitive outcome study. We're hoping to link with Ambulance Victoria, that links with the AusRock investigators, possibly down the track. We've got strong plans to submit to the NHMRC for a multi-centre randomised trial, and I would urge anyone here to please stay in touch with me, being in touch if you'd like to participate. I don't expect that we would include biomarkers in every patient's on every site, but one would suggest that the reducing of the respiratory rate by a little movie of a wrist is achievable. Cardiac arrest is a big community burden. I remember not too long ago standing at the bedside of a young man, only 2 or 3 years older than myself, married like myself, 2 kids like myself, and I think it's truth, if that was me in the bed I would not be pleased, A, for myself, but also for the impact on my family. So one would urge that if we can make an impact simply by tailoring an intervention that's at our fingertips, that we should do so. So one would, I'm really excited, even though I'm a bit nervous, but I'm really excited about taking this to a larger study to hopefully find a definitive outcome that we can apply. It's cheap. Yeah, it's cheap.
So you talked and presented in the talk, but also spoke about just now about biomarkers, and we love biomarkers because they're going to tell us everything. What are some of the challenges of doing research with biomarkers, though?
So biomarkers, it's essentially you have to have sites willing and able to do it. You have to have staff that are aware of what to do with the blood and where to put it. Then you have to have the storage and batch analysis mechanisms set in place. I think the clinical trial group able to facilitate that wherever possible. Biomarkers really provide some of the granular data that you need to support your study. You really have to understand biomarkers as well as functional outcomes, so that in essence you leave no stone unturned. We are delighted that NSE and S100B are well studied post cardiac arrest, and we've included them from the start. So the biomarkers do indeed provide valuable material and are an arsenal that can be in your favour. Yeah. Yep. Thank you very much.